Hello, here we will discuss cerebrospinal fluid shunting for hydrocephalus by Jeorpum Prashant, Won Kim, and Marvin Bergsnyder from the Department of Neurosurgery, University of California, Los Angeles. The objectives of this talk are to review the basic components of a shunt system, with a particular focus on shunt valves and the decision-making behind valve selection. We will also discuss concepts of pulsatile CSF dynamics and how placement of a ventricular shunt affects the intracranial pressure and results in CSF drainage. Finally, we will review shunt overdrainage and the methods by which to minimize complications associated with shunt placement. Although we will be primarily discussing CSF shunting, it is important to always consider endoscopic third ventriculostomy when patients present either for initial shunt placement or revision. Proceeding automatically with a shunt operation, particularly in patients presenting with shunt failure, potentially robs the patient of an opportunity to live shunt-free. Clinicians should investigate the etiology and ventricular anatomy in every case of hydrocephalus. In some cases, even patients with presumed communicating hydrocephalus instead have a ventricular obstruction that clinicians can readily visualize using modern high-resolution magnetic resonance imaging, such as CIS or Fiesta sagittal sequences. In our experience, adult patients shunted early in childhood have a particularly high incidence of intraventricular or obstructive hydrocephalus. The basic components of a shunt system are the proximal or ventricular catheter, the shunt valve, and the distal catheter. As the proximal and distal catheter have minor variations, we will focus this discussion on the shunt valve. However, it is important to note that in recent years, antibiotic-impregnated catheter systems have become available, and evidence suggests that using these catheters may lead to a lower post-operative infection rate. The vast majority of modern valves are differential pressure valves. The basic design of this valve is more than 50 years old and most commonly consists of a tiny sphere situated on a ring, with a spring pushing the sphere downward on the ring. CSF passes through the ring orifice and elevating the ball if the pressure exceeds the pressure exerted by the spring. This creates a one-way flow mechanism because reverse flow will not occur as the ball seats down onto the ring. A common misconception is that the valve opening pressure must be lower than the measured CSF pressure for CSF to flow across the valve. In our in vivo studies, we have demonstrated that the interaction between CSF pressure and valve function is not straightforward and that, in general, more CSF drainage occurs than one might predict. In fact, even while setting the shunt valve higher than the preoperative average intracranial pressure, CSF flow does occur, and the intracranial pressure decreases post-shunt placement. Hydrocephalus is a heterogeneous disorder with a wide range of intracranial pressures, ventricular compliance, and other features across patients. In our opinion, there is no single valve mechanism, design, or arrangement that is clearly the best, nor one that will be adequate for every hydrocephalus patient. There are some valves and valve settings, however, that are poorly suited for adult hydrocephalus and will likely result in higher complication rate. In our retrospective evaluation of 114 consecutive NPH patients surgically treated with a CSF shunt, the histogram distribution of the final valve opening pressure revealed a roughly Gaussian distribution, with most patients in the 120 to 140 millimeters water range. This finding closely agrees with other large NPH studies. In our experience, with other etiologies of adult hydrocephalus, we find that most adult patients will require at least one shunt adjustment during their lifetime. Therefore, we recommend implanting an adjustable valve rather than a fixed pressure valve in all patients. Individual attributes of shunt valve should also be taken into consideration. Shunt valve prominence or profile is particularly important in patients who have fragile or thin scalp or who have received radiation in the past and are high risk for wound dehiscence. Many newer valves are advertised as MRI resistant to 3 Tesla magnets. In patients who may get frequent MRI scans, such as those with brain tumors who require surveillance, this is an important attribute to consider. Finally, the ease of adjustment of any valve and the use of its programmer should be taken into account. Overdrainage is a condition that is caused by excessive CSF drainage, leading to intracranial hypotension and is of clinical significance. In shunted patients, the finding of negative intracranial pressure when the patient is in the upright position is expected with differential pressure valves. The diagnosis of overdrainage must be based on appropriate symptoms and/or imaging findings. Overdrainage typically manifests as either postural headaches with or without nausea, or imaging evidence of pathologic subdural fluid collections. Many patients with shunted hydrocephalus will display diffuse pachymeningeal enhancement on MRI. It is important to note that this is a common finding and does not indicate overdrainage. However, the presence of expanding subdural hygromas or hematomas should prompt evaluation and consideration of treatment. For most patients, a valve opening pressure setting should exceed the mean ventricular pressure. In vivo ICP data suggests that the etiology of shunt overdrainage with DPVs is in many, if not most cases, a result of valve opening pressure selection that is too low. The first step in the treatment of a patient with symptomatic overdrainage is to increase the valve opening pressure by at least 30 millimeters of water, which will usually alleviate postural headache symptoms within 1 hour of the intervention. The use of adjustable valves obviates the need for a shunt revision in most of these cases. In the situation in which the patient is already at the maximum valve opening pressure of an adjustable valve, or has a fixed pressure or other valve, a shunt revision is typically required to either add an anti-siphon or a gravitational device, or, with the latter scenario, change the valve to an adjustable valve with a higher range of pressures. In our practice, we find that patients with obstructive hydrocephalus or aqueductal stenosis who are not ATV candidates are at higher risk for overdrainage and subdural hematoma formation. Additionally, in very tall patients, our cutoff is 6 feet, in which the greater distance between the ventricle and the abdominal cavity may result in overdrainage. And in patients who suffer severe overdrainage headaches with low volume of CSF withdrawal, an anti-siphon device should be considered. The adult slit ventricle syndrome is an ill-defined disorder, but the key components are a symptomatic shunted patient with slit or collapsed ventricles seen on CT or MRI. Although relatively few in number, these patients represent a disproportionate amount of clinical effort expended, with frequent emergency department visits and requests for office visits. The syndrome occurs more commonly in patients who have been shunted for many years, either as an adult or in childhood. The apposition of the ventricular catheter to the ventricular wall increases the chance of ingrowth of ependymal cells or cord plexus. Left untreated, the symptoms may progress to more continuous headaches, presumably owing to the complete mechanical obstruction of the shunt system. Therefore, slit ventricle syndrome is actually an underdrainage syndrome created by a preceding period of overdrainage. Within the first year, shunts fail at an extraordinary rate of up to 40% and show nearly a 10% infection rate. In a recent study, pediatric patients underwent an average of 2.66 shunt revisions over 20 years, and while pediatric patients have significantly higher rates of shunt failure than adults, it is clear that the shunt operation has one of the highest associated complication rates in neurosurgery. Therefore, complication avoidance is key to the success of this operation. We prefer the frontal or coronal entry site for adult hydrocephalus patients, and there is some evidence that this site has a higher rate of successful ventricular placement and may have a lower rate of shunt failure. As a general rule, every shunt incision should be carefully planned so that it does not directly overlie a shunt component. Failure to do so increases the risk for skin breakdown. With respect to distal site, we generally opt for the peritoneal location unless a patient has severe obesity or significant prior abdominal surgical history that may have resulted in peritoneal adhesions, in which case a ventricular atrial shunt is offered. Of note, there is increasing literature on the use of laparoscopic assisted peritoneal shunt placement, even in those patients who may traditionally have difficult peritoneal access. As discussed previously, the shunt valve setting can be higher than the average intracranial pressure and still lead to CSF flow and reduction in intracranial pressure. Therefore, to prevent complications of overdrainage and ventricular collapse, we prefer to set the shunt valve setting higher initially and dial down as needed per symptomatic evaluation. Finally, a meticulous attention to detail with regard to surgical site preparation, timing, and handling of shunt components, and double gloving by all surgical staff and surgeons should be considered standard of care for all shunt operations.